Now let's talk about the pelvic walls. So the pelvis is in the region of the trunk that lies inferior to the abdomen. Although the abdominal and the pelvic cavities are continuous, the two regions of the abdomen and the pelvis usually are described separately. The term pelvis is loosely applied to describe the region where the trunk and the lower limbs will meet. The word pelvis means basin, so it is more correctly applied to the skeletal region, that is the pelvic girdle or the bony pelvis. Thus, the pelvis is a bowl-shaped bony structure. The main function of the bony pelvis is to transmit the weight of the body from the vertebral column to the femurs. In addition, it contains, supports, and protects the lower parts of the GIT and the urinary tracts and the male and female internal organs of reproduction. It also has important nerves, blood vessels, lymphatic tissues, and it also provides attachment for the trunk and for the lower limb muscles. Now let's talk about four bones that make up the bony pelvis. So we have two hip bones, which are os coxae, and these hip bones are going to form the lateral and anterior walls, and we have the sacrum and the coccyx. So these are the four bones that we have in the bony pelvis. So I told you about the sacrum and coccyx. So sacrum and coccyx are part of the vertebral column. They are going to form the posterior wall. The two hip bones are going to articulate with each other anteriorly with the pubic symphysis and posteriorly with the sacrum of the sacroiliac joint. The bony pelvis that forms a strong basin-shaped structure. About the pelvis. So first of all, we have a pelvic brim. Pelvic brim is going to divide the pelvis into two parts. Pelvic brim is formed by the sacral promontory, and so sacral promontory is on the anterior and upper margin of the first sacral vertebra, or S1. Pelvic brim is formed by the sacral promontory, or S1, and pelvic brim is going to divide the pelvis into two parts. Pelvic brim is itself formed by the sacral promontory, S1. Behind the iliopectineal lines that run downwards and forwards around the inner surface of the ileum. So iliopectineal lines are present laterally, and what is present anteriorly? Anteriorly we have the symphysis pubis. So just remember this with PLA and SIS. Let's just talk about false pelvis and true pelvis. So why is the false pelvis called the false pelvis? Because it does not have the pelvic contents, but instead it has the abdominal cavity and it is present above the pelvic brim. Now let's talk about true pelvis. True pelvis has the pelvic cavity and it is present below the pelvic brim. Orientation of the pelvis. Understand that the correct orientation of the bony pelvis relative to the trunk is with the individual standing in the anatomical position. The front of the symphysis pubis and the anterior superior iliac spines lie in the same vertical plane. This means that the pelvic surface of the symphysis pubis faces upwards and backwards, and the anterior surface of the sacrum is directed forward and downwards. So symphysis pubis is directed upwards and backwards, and sacrum is directed forwards and downwards. Now let's talk about the false pelvis. It is of little clinical importance. Now let's talk about the boundaries of the false pelvis. So posteriorly, lumbar vertebrae are present. Anteriorly, anterior abdominal wall is present, and laterally, iliacus and iliac fossa are present. The false pelvis flares out at its upper end, and it is considered to be a part of the abdominal cavity. It supports the abdominal contents, and after the third month of pregnancy, it also helps to support the gravid uterus. During the early stages of labor, it helps to guide the fetus into the true pelvis. Let's talk about true pelvis. True pelvis, the anatomy of the true pelvis in the females is important for obstetrics because it forms a bony canal through which the child passes during birth. The true pelvis in both sexes has an inlet, an outlet, and a cavity. Okay, now let's talk about the boundaries of the pelvic outlet. So pelvic outlet key posterior boundary is going to be coccyx, and posterior boundary is also going to be the sacrotuberous ligament. And let's talk about the lateral boundaries. So first of all, laterally we have ischial tuberosities, and anteriorly we're going to have the pubic arch. Okay, laterally we also have other things which are going to be called as the sciatic notches. So from the sciatic notches, greater and lesser sciatic foramina are going to pass, and from obstetric standpoint, because the sacrotuberous ligament is strong and relatively inflexible, so sacrotuberous ligament is also considered a boundary of the pelvic outlet. So it is more specifically, it is the posterior boundary of the pelvic outlet. And sacrotuberous ligament and sacrospinous ligament are going to form the greater and lesser sciatic foramen. Thus, the outlet is going to be diamond shaped with the ischiopubic rami and the pubic symphysis present anteriorly, and the sacrotuberous ligament is present posteriorly, and the coccyx is also present posteriorly. So these are the boundaries of the pelvic outlet. Now let's talk about the pelvic cavity. So here we can see the pelvic cavity. Pelvic cavity is a short, curved canal, and it has a shallow anterior wall and a much deeper posterior wall. It lies between the inlet and outlet. Now let's talk about the pelvic walls. The bones and ligaments that are partly lined with muscles, covered with fascia and parietal peritoneum, will form the walls of the pelvis. So the pelvis has anterior, posterior, and lateral walls and an inferior wall or floor. Anterior pelvic wall is the shallowest part, and it is formed by the bodies of the pubic bones, the pubic rami, and also the pubic symphysis. Now let's talk about posterior pelvic wall. It is extensive, and it is formed by sacrum and coccyx, and also by the piriformis muscle and the coverings of the parietal pelvic fascia. Now let's talk about sacrum in more detail. Sacrum has 5 rudimentary vertebrae which are fused together to form a single wedge-shaped bone which looks like this. It has an anterior concavity, so when we view it anteriorly, we're going to see a cave-like thingy. The upper border or the base of the bone is going to articulate with L5. The narrow inferior border is going to communicate with the coccyx, and it is going to form laterally. It is going to form the sacroiliac joint by articulating with two iliac bones. It is going to form two sacroiliac joints, of course. Anterior and upper margin of S1 is going to bulge forward to form the sacral promontory. So, where we measure the size of the pelvis. So it is very important, posterior margin of the pelvic inlet. Now let's talk about sacral vertebral foramina. Sacral vertebral foramina will together form the sacral canal. The lamina of the S5 and sometimes of S4 will fail to meet in the midline, forming the sacral hiatus. The sacral canal has nerves. So what are the nerves? They present spinal nerves, sacral and coccygeal spinal nerves, and lumbar spinal nerves as well. It also has filum terminale and fibrofatty material. It also contains the lower part of the subarachnoid space, and down as far as the lower border of the S2. Anterior and posterior surfaces of the sacrum will possess 4 pairs of anterior and posterior sacral foramina respectively for the passage of the anterior and posterior rami of the upper 4 sacral nerves. The sacrum is usually wider in proportion to its length in female than in the male. The sacrum is tilted forward so that it forms an angle with the L5 called the lumbosacral angle. Now let's talk about the coccyx. So coccyx has 4 vertebrae which are fused together to form a small triangular bone which articulates at its base with the lower part of the sacrum, and the coccygeal vertebrae only has bodies only, but the first vertebrae, which is C1, is going to possess rudimentary transverse processes and cornua. The cornua are the remains of the pedicles and the superior articular processes, and it is going to project outwards to articulate with the cornua of the sacrum or the sacral cornua. Now let's talk about the piriformis muscle, which comes from the sacrum, and it is inserted through the greater sciatic foramen, which bypassing laterally towards the gluteal region or the lateral pelvic wall. So lateral pelvic wall is formed by the part of hip bone below the pelvic inlet, and also sacrotuberous ligament and sacrospinous ligament, as well as obturator internus and obturator membrane. So obturator internus muscle and is covering fascia as well. Now let's talk about the hip bone. So in children, each hip bone or os cocci has superiorly ilium, inferiorly and posteriorly ischium, and anteriorly and inferiorly pubis. Triradiate cartilage is going to join these 3 separate bones at the acetabulum. At puberty, they are going to fuse together to form one large irregular bone. The hip joint is going to articulate with the sacrum at the sacroiliac joints, and it is going to form the entire lateral wall of the pelvis. They also articulate with one another anteriorly at the symphysis pubis. On the anterior surface of the hip bone, the deep depression, which is the acetabulum, which articulates with the hemispherical head of the femur. Behind the acetabulum, there is a large notch, which is a greater sciatic notch, which is separated from the lesser sciatic notch by the spine of ischium. The sciatic notches are converted into greater and lesser sciatic foramina by the sacrotuberous ligament and sacrospinous ligament. The ilium is the upper flattened part of the hip bone. It has a crest, so it has a iliac crest. Iliac crest runs between the anterior and posterior superior iliac spines. Below these are the anterior and posterior inferior iliac spines. On the inner surface of the ilium, there is a large auricular surface for articulation with the sacrum. So iliopectineal line is going to run forward and downward and forward around the inner surface of the ilium, and it is going to divide the false pelvis from the true pelvis. Ischium is the inferior and posterior part of the hip bone and possesses an ischial spine and ischial tuberosity. Pelvic outlet की lateral walls को form करते हैं. Pubis is the anterior part of the hip bone, and it has a body and it has a superior and inferior pubic rami. The body of the pubis has pubic crest as well as pubic tubercle and articulates with the pubic bone of the opposite side at the pubic symphysis. In the lower part of the hip bone, there is a large opening which is the obturator foramen, which is bounded by the parts of ischium and pubis. The obturator membrane is going to fill in most of the obturator foramen. Now let's talk about the pelvic wall and the floor muscles. So for that, I have a mnemonic which is POLC. So P for piriformis, O for obturator internus, L for the levator ani, and C for the coccygeal muscle. Now let's talk about their origins. So where is the piriformis going to arise from? So the piriformis muscle is going to arise from the sacrum, and the obturator internus, of course, it is going to come from the obturator membrane and also the adjoining part of the hip bone. Now let's talk about levator ani. So what is the origin of the levator ani? From the pubis, from the obturator internus, fascia, and also from the ischial spine. What about the coccygeus? Coccygeus is just coming from the ischial spine. So levator ani and coccygeus both are coming from the ischial spine, Now let's talk about the insertions. So piriformis and obturator internus are both inserted into the same thing, which is the greater trochanter of the femur. And their action is going to be lateral rotation of the femur at the hip joint. Now let's talk about their nerve supply. Piriformis and obturator internus are going to be supplied by the sacral plexus, both. Now let's talk about the insertion of the levator ani and the coccygeus muscle. So the levator ani is going to be inserted somewhere which has the prefixes of ani. So we have the perineal body, we have the anococcygeal body, and we have something which is PRAV. So what is that? That is the prostate, the rectum, the anal canal, as well as the vagina. What about the insertion of the coccygeus? Coccygeus, of course, is going to be inserted into the sacrum and coccyx for the nerve supply of the levator ani and the coccygeus muscle. So levator ani and coccygeus are both supplied by S4, but levator ani is also supplied by pudendal nerve, and coccygeus is also supplied with S4 and S5. What are the actions of the levator ani? It is just going to support the pelvic viscera, and it is also going to act as a sphincter for the anorectal junction and the vagina. And what is the function of the coccygeus? It is going to flex the coccyx, and it is also going to assist the levator ani in supporting the pelvic viscera. Let's talk about the obturator membrane. Obturator membrane is a fibrous sheath that almost completely closes the obturator foramen, and it leaves behind a small gap, which is the obturator canal, for the passage of the obturator nerve and the obturator vessels. It's also going to enter the thigh. Now let's talk about the sacrotuberous ligament. Sacrotuberous ligament is strong, and it extends from the lateral part of the sacrum and coccyx, and the posterior inferior iliac spines, and towards the ischial tuberosity. Now let's talk about sacrospinous ligament, which is strong and triangular. It is attached by the base to the lateral part of sacrum and coccyx, and by the apex to the ischial spine. So what are the functions of the sacrotuberous and sacrospinous ligament? They will prevent the lower end of the sacrum and coccyx from being rotated upward at the sacroiliac joint when a person is sitting by the weight of the body. The two ligaments also convert the greater and less sciatic notches into greater and less sciatic foramen. Now let's talk about obturator internus muscle, which arises from the pelvic surface of the obturator foramen and obturator membrane. The muscle fibers will converge to a tendon, which leaves the pelvis through the lesser sciatic foramen and inserts into the greater trochanter of the femur. Now let's talk about inferior pelvic floor. So the floor of the pelvis supports the pelvic viscera, and it is formed by pelvic diaphragm and associated fascia. Pelvic floor stretches across the pelvis and divides it into main pelvic cavity above, which contains the pelvic viscera, and perineum is present below. Now let's talk about pelvic diaphragm, which has paired levator ani and coccygeus muscle and the covering fascia. It is incomplete and to allow the passage of urethra in males and urethra in vagina in females. Now let's talk about levator ani muscle, which is a wide thin sheet, which is forming the larger, more anterior portion of the pelvic diaphragm. It has a linear origin from the back of the body of the pubis, a tendinous arch, which is formed by the thickening of the fascia covering the obturator internus. So it arises from the pubis and obturator internus fascia, as well as ischial spine. From this extensive origin, it sweeps downwards and medial to their insertion. So it has anterior fibers, intermediate and posterior fibers. So anterior fibers are going to be, for this remember, LPSV and perineal body. So levator prostatae or sphincter vaginae, they are going to form a sling around the prostate gland or the vagina and insert into massive fibrous tissue, which is called the perineal body, in front of anal canal. So levator prostatae is going to support the prostate and stabilize the perineal body, and sphincter vaginae is going to constrict the vagina and stabilize the perineal body. Now let's talk about intermediate fibers. Intermediate fibers have puborectalis as well as pubococcygeus, which are going to pass and posteriorly, and they're going to insert into a small fibrous mass called anococcygeal body between the tip of the coccyx and the anal canal. Now let's talk about posterior fibers. So posterior fibers have iliococcygeus. They are going to insert into anococcygeal body and the coccyx. Let's talk about the action of the levator ani muscles. So the levator ani muscles from the two sides will form an efficient muscular sling that supports and maintains the pelvic viscera position, and they will also act as a sphincter for the vagina and also for the anorectal junction, and they will also resist to intra-abdominal pressure, as in straining and expulsive efforts of the abdominal muscles. Now let's talk about coccygeus muscle, which is a small triangular muscle, more posterior portion of the pelvic diaphragm. Talk about pelvic joints. 4 major joints are present in the pelvis. They include the paired sacroiliac joints, pubic symphysis, and also sacrococcygeal joint. Additional joints may occur in the immature pelvis between ilium, ischium, and pubis. Elements of the os cocci or the hip joints between the sacral vertebrae and the sacrum. Now let's talk about sacroiliac joints, which are strong synovial joints. They are formed between the auricular surface of the sacrum and the iliac joints and the iliac bones. The sacrum has the weight of the trunk, and apart from interlocking of the irregular articular surfaces, shape of the bones does not have any other contribution, and it also contributes later to the stability of the joint. Strong posterior and introitious sacroiliac ligaments will suspend the sacrum between two iliac bones. So how is the sacrum suspended between two iliac bones? By some ligaments, which are posterior and introitious sacroiliac ligaments. The anterior sacroiliac ligament is thin, and it lies in front of the joint. The weight of the trunk will thrust the upper end of the sacrum downwards and rotate the lower end of the sacrum upwards. To prevent this, we have sacrotuberous and sacrospinous ligaments. The iliolumbar ligament is going to connect the L5 to iliac crest. Now let's talk about the movements of sacroiliac joints. So a small but limited amount of movement is possible at the sacroiliac joints. In older people, the synovial cavity disappears and joint is fibrosed somehow. Therefore, the primary function is to transfer the weight of the body from the vertebral column to the bony pelvis. Now let's talk about the nerve supply. It is from the sacrospinal nerves or sacral plexus. Now let's talk about symphysis pubis, which is a cartilaginous joint between two pubic bones. The articular surface is covered with a layer of hyaline cartilage, and it is connected together by fibrocartilaginous disc. Ligaments that extend from one pubic bone to the other will surround the joint. No movement possible. Sacrococcygeal joint is a cartilaginous joint between the bodies of the last sacral vertebrae and the first coccygeal vertebra. Ligaments will join the cornu of the sacrum and coccyx. Now let's talk about the movements of sacrococcygeal joints. Extensive flexion and extension are possible at this joint. Now let's talk about the joint changes with pregnancy. During pregnancy, SI and SC will get soft. So sacroiliac and sacrococcygeal joint will undergo softening in response to hormones, thus increasing their mobility and increasing the potential size of the pelvis during childbirth. Hormones which are responsible for are estrogen and progesterone, produced by the ovary and the placenta, and additional hormone relaxation is also produced by these organs. It can have a relaxing effect on the pelvic ligaments. Now let's talk about joint changes with age. Obliteration of the pelvic cavity in the sacroiliac joint occurs in both sexes after middle age. Now let's talk about sacroiliac joint disease. This is somehow important. The sacroiliac joint is innervated by the lower lumbar and the sacral nerve, so that disease can produce low back pain as well as pain radiating along the sciatic nerve, which is sciatica. So sciatica and lower back pain is also caused by sacroiliac joint disease. Sacroiliac joint is inaccessible to clinical examination. However, the joint comes closest to the surface at a small area which is just medial to and below the posterior superior iliac spine. In disease of the lumbosacral region, movements of the vertebral column in any direction will cause pain in the lumbosacral part of the column. In sacroiliac joint disease, pain is extreme on rotation of the vertebral column, and it is worst at the end of flexion. The lateral movement or the flexion is going to cause pain because the hamstring muscle is going to hold the hip bones in position while the sacrum is rotating forward as the vertebral column is flexed. Now let's talk about something extremely important, which is the biological sex. Anatomical differences are going to exist between the bony pelvis in both of the genders, and specifically in female for childbearing. The stronger muscles in males are responsible for thicker bones and more prominent bony markings. Now let's talk about the features. So here we can see that this is the pelvic inlet, pelvic outlet, pelvic cavity, and pubic arch. So the pelvic inlet in female is going to be transversely oval, and in males it is going to be heart-shaped. And pelvic outlet is going to be larger in female than in the male. The ischial spine, because the ischial spine is everted in female, but it is inverted in male. Now let's talk about pelvic cavity. This is going to be roomier in female as in male. And also the distance between pelvic inlet and outlet is going to be shorter in female as compared to male. Now let's talk about the subpubic angle or pubic arch. Subpubic angle is going to be more rounded and wider in female than in male. Now let's talk about false pelvis. False pelvis is shallower in female and deep in the male. Sacrum is going to be shorter, wider, and flatter in female than in male. Let's talk about pelvis as a basin with holes in its walls. Bones and ligaments are going to form much of the walls of the pelvis. These are partly lined with muscles. Obturator internus piriformis covered with fascia and parietal peritoneum. The attachments of the gluteal and obturator externus muscle are on the outside of the pelvis. Thus, the greater part of the bony pelvis is sandwiched between inner and outer muscles. The basin has anterior, posterior, lateral, and inferior wall, formed by the levator and coccygeal muscle and their covering fascia. The basin has several holes. The posterior wall has holes on the anterior surface of the sacrum, which are the anterior sacral foramina for the passage of anterior of the sacrospinal nerves. Sacrotuberous and sacrospinous ligaments will convert the greater and lesser sciatic notches into greater and lesser sciatic foramina. Greater sciatic foramina is going to provide an exit from the true pelvis into the gluteal region for the PSG, which are the pudendal sciatic and gluteal nerves, and the lesser sciatic foramina is going to provide entry from the gluteal region to the perineum for the pudendal nerves. Also internal pudendal vessels. The lateral pelvic wall has a large hole, which is obturator foramen, which is closed by obturator membrane, except for a small opening that permits the obturator nerve to leave the pelvis and enter the eye. The pelvic measurements in obstetrics are extremely important. Let's talk about internal pelvic assessments. So, internal pelvic assessments are made by vaginal examination during the later week of pregnancy when the pelvic tissues are softer and more yielding than the newly pregnant condition. Needless to say, बहुत ज़्यादा expertise चाहिए होती है, ठीक है, pubic arch. So for examining the pubic arch, just see whether it is broad or angular. So you have to spread the fingers under the pubic arch and examine the shape. And examiner's forefingers should be able to rest comfortably in the angle below the symphysis. Now for the lateral walls, check whether they are concave, straight, or converging. So palpate the lateral walls and determine whether they are concave, straight, or converging. The prominence of ischial spine has to be noted, and the position of sacrospinous ligaments as well. Now let's talk about the posterior wall. So sacrum is palpated to determine whether it is straight or well correct. Finally, if the patient has relaxed the perineum sufficiently, an attempt is made to palpate the promontory of the sacrum. The second finger of the examining hand is placed on the promontory, and the index finger of the free hand outside the vagina is placed at the point of the examining finger on the lower border of the symphysis. So between the promontory and symphysis, what are we going to measure? We are going to measure the diagonal conjugate of the pelvis, which is about 5 inches. This is from the promontory to the symphysis. So this is, and the entire posterior diameter from the sacrococcygeal joint to the lower border of symphysis is then estimated. So thirdly, we have to measure the ischial tuberosities, which are distances between the ischial tuberosities, which are present on the lateral walls, pelvic outlet. It may be estimated by using the closed fist method. and it measures about 4 inches, but it is difficult to measure exactly, and it was a HLD velocity measurement. Now let's talk about female pelvis in more detail. Difficult deformities may be responsible for dystocia, which is difficult labor. Contracted pelvis may obstruct the normal passage of the fetus. It may be indirectly responsible for dystocia by causing conditions which are malpresentation and premature rupture of the fetal membrane, and also uterine inertia. The cause of the pelvic deformities may be congenital or acquired from disease, poor posture, or fractures caused by injury. Pelvic deformities are more common in females who have been raised in a poor environment and they have suffered from rickets at some point of their childhood or youth. The pelvis can be classified into 4 general types or morphological types. So, gynoid pelvis. This looks like this, a little bit oval. This is the most common type in 41% females. Now let's talk about the android type, which is more common in white females. So android type is more common in males, and it is funnel-shaped pelvis with a contracted outlet. Okay, now let's talk about the anthropoid pelvis. Anthropoid type is mostly seen in black females. It is long, narrow, and oval-shaped, as we can see here. Now let's talk about the platypuloid type. So platypuloid type is like this. And it is found in only 2% of women, and it has a wide pelvis flattened at the brim with the promontory of the sacrum pushed forward. Now let's talk about pelvic fascia, which is formed of connective tissue, and it is continuous above with the fascia lining the abdominal walls. Below the fascia is continuous with the fascia of the perineum. The pelvic fascia can be divided into parietal and visual layers. Parietal pelvic fascia lines the walls of the pelvis, and it is named according to the muscles it overlies. The pelvic diaphragm is anteriorly deficient. The parietal pelvic fascia will become continuous through the opening with the fascia covering the inferior surface of the pelvic diaphragm. In the perineum, it covers the perineal membrane and forms the fascia deep to that structure. Visual pelvic fascia condensations will form the ligaments, and it is going to support all the pelvic viscera. In certain locations, it is going to thicken and extend from the viscus to the pelvic walls and provide added support. And condensations हो जाएगी, and then ligaments, pubo-vesical and sacrocervical ligaments बन जाएंगे. Cervical facial ligaments. In the female, facial ligaments are attached to the uterine cervix, and they are of clinical importance because they assist with the support of the uterus and prevent uterine prolapse. Visceral pelvic fascia around the uterine cervix and vagina is commonly referred to as parametrium. Let's talk about pelvic peritoneum. Parietal peritoneum lines the pelvic walls and it is reflected onto pelvic viscera. It becomes continuous with the visceral peritoneum. Now let's talk about the fracture of the false pelvis. So fracture of the false pelvis are caused by direct trauma. They occasionally occur. The upper part of ileum is seldom displaced because of the attachment of iliacus muscle inside and gluteal muscles outside. Now let's talk about true pelvis fractures. Mechanism of fractures of true pelvis can be better understood if we regard pelvis not only as a basin but also as a rigid ring. Ring is made up of pubic rami, ischium, acetabulum. Ilium sacrum is joined by strong ligaments at the sacroiliac and symphyseal joints. If the ring breaks at one point, the fracture will be stable and no displacement will occur. However, if the ring breaks at 2 points, the fracture will be unstable and displacement will occur because the postvertebral and the abdominal muscles will shorten and they will elevate the lateral part of the pelvis. The break in the ring may occur not as a result of fracture but as a result of disruption of sacroiliac and symphyseal joints. Fracture of the bone on either side of the joint is more common than disruption of the joint. The forces which are responsible for the disruption of the bony ring may be anterior posterior compression, lateral compression, or shearing. Trauma to the true pelvis can result in fracture of the lateral mass of the sacrum. A heavy fall on the greater trochanter of the femur may drive the head of the femur through the floor of the acetabulum into the pelvic cavity. Now let's talk about sacrococcygeal fractures. The fractures of the lateral mass of the sacrum may occur as a part of pelvic fracture. The fractures of the coccyx are rare. However, coccydynia, which is coccygeal pain, is common and it is usually caused by direct trauma to the coccyx, as in falling down a flight of stairs. Anterior surface of the coccyx can be palpated in a rectal examination. Minor pelvic fractures. Anterior superior iliac spine may be pulled off by the forceful contraction of the sartorius muscle in athletes, and anterior inferior iliac spine can be due to forceful contraction of the rectus femoris, and ischial tuberosity may be due to the can be avulsed by the contraction of the hamstring muscle. And healing may occur by fibrous union, possibly resulting in elongation of the muscle and some reduction in muscular efficiency and acme of complications. Fractures of the true pelvis are commonly associated with injuries to the soft pelvic tissues. If damaged, the thin pelvic veins, namely the internal iliac veins and the tributaries that line parietal pelvic fascia beneath the parietal peritoneum, can be the source of massive hemorrhage, which may be life-threatening. The male urethra is often damaged, specifically in the vertical shear fractures, and disrupts the urogenital diaphragm. The bladder, which lies immediately behind the pubis in both of the sexes, is occasionally damaged by spicules of the bones. A full bladder is more likely to be injured as compared to an empty bladder. The rectum lies within the concavity of the sacrum and it is protected and rarely damaged. Fractures of the sacrum or ischial spine may be thrust into the pelvic cavity, tearing the rectum. The nerve injuries follow the sacral fractures. The laying down of the fibrous tissue around the anterior or posterior roots of the branches of the sacral spinal nerves can result in persistent pain. Damage to the sciatic nerve may occur in fractures involving the boundaries of the greater sciatic knots. The fibular or peroneal part of the sciatic nerve is most often involved, resulting in the inability of a conscious patient to dorsiflex the ankle joint or failure of unconscious patient to reflexly plantar flex or ankle jerk of the foot. Now let's talk about the pelvic floor. Pelvic diaphragm is gutter-shaped sheet of muscle which is formed by levator ani and the coccygeal muscle and their covering fascia. The muscle fibers on the two sides will slope downwards and backwards from their origins to the midline, producing a gutter that slopes downwards and forwards. A rise in intra-abdominal pressure caused by a contraction of the diaphragm and the muscles of the anterior and lateral abdominal walls is contracted by the contraction of the muscles forming the pelvic floor. By this means, the pelvic viscera are supported and it does not drop out through the pelvic outlet. Contraction of the pubirectalis will greatly assist the anal sphincters in maintaining the continence under these conditions by pulling the erectile junction upwards and forwards. However, during the act of defecation, the vagina is going to continue to support the pelvic viscera, but the pubirectalis will relax with the anal sphincters during defecation. Now let's talk about female pelvic floor's functional significance. It serves as an important function during the second stage of labor at the pelvic inlet. The widest diameter is transferred, so the longest axis of the baby's head, anterior posterior axis, going to take up the transverse position. When the head reaches the pelvic floor, the gutter shape of the floor will cause the baby's head to rotate so that its long axis comes to lie in the anterior posterior position. The occipital part of the head will now move downwards and forwards along the gutter until it lies under the pubic arch. As the baby's head passes through the lowest part of the birth canal, the small gap that exists in the anterior part of the pelvic diaphragm will become enormously enlarged so that the head may slip into the perineum. Once the baby has passed through the perineum, the levator and muscles will recoil and take up their previous position. Now let's talk about pelvic floor injury. During a difficult childbirth, it results in loss of support for pelvic viscera, leading to uterine and vaginal prolapse, herniation of the bladder, cystocele, and alteration of the position of the bladder, neck, and urethra, leading to stress incontinence. In the stress incontinence, the patient will dribble urine whenever the intra-abdominal pressure is raised, as in cuffing. Prolapse of the rectum may also occur. Now let's talk about partial fusion of the sacral vertebrae. S1 and S2 can be fused together occasionally, and S1 and L5 can also be fused.